Professor Anthony Jorm, Tony, and your lovely wife, Betty.
It's a wonderful sunny day here in Coffs Harbour.
All is good, thank you.
It's an honor and privilege from my end, and thank you, both of you. During a recent conversation with a psychiatrist, he was telling that trauma is the most underserved emotional phenomenon, and it can be long-term, even generational. How to guide, if someone going through that?
How people experience trauma and then process it and react to it is different everywhere. Some people go through horrible natural disasters and they seem to come through unscathed, and for other people they're not. It affects them for the rest of their life. But the way we look at them is that, they may get high anxiety, really troublesome anxiety. They may get a real mood disturbance in their motivation and their depression. They may lose touch with reality a bit and have some psychosis. They may turn to drugs and alcohol for some sort of coping. So from the mental health first aid point of view, that's what we look at. What are the symptoms we're seeing, and how can we help with what we know is the best evidence for those type of emotions? Trauma is what a person says it is. And someone might say, my darling pet dog dying has been the biggest trauma in my life. And whereas someone else may scoff at that and say, well, it's only a dog or whatever. Trauma is what the person says it is. Over to you, Tony.
I think there are situations like in mental health aid where the person has recently had a traumatic experience, like they've been a victim of crime or in an accident or been a natural disaster or something like that. And I think in those situations, people generally have a higher level of distress in the short term, and over time it will, in most cases, resolve. And for some people it continues, and those people might eventually be diagnosed with PTSD. But I think that's where, first aiders can have an important role just in that period for weeks or months immediately following the traumatic event, and how to respond to the person in a supportive way and not make the situation worse, which could be done in some ways if people try and force the person to talk about it or something like that. When the person's ready to talk, just be there to listen, really the important thing. Don't encourage avoidance strategies either. But then the other situation is where people have traumatic experiences early in life. People often describe these as adverse childhood experiences, and you're dealing with things like the extreme child abuse, sexual, physical, emotional abuse or neglect. And we know that they are very important risk factors, not only in childhood, but throughout life. So you can look at people who have, diagnosable mental illnesses at any point in life through to old age and compare them to people, the rest of the population. You'll find they more often have these adverse childhood experiences. So even if you're elderly and you develop a mental illness or have a long-term mental illness, you'll find those people more often had these. So adverse childhood can have very long-lasting effects on risk for mental illness. So that gets beyond a first aid situation where you're dealing with long-term effects of that sort. But I think it's going to be important there where we get much more into preventive work to try and reduce those experiences. I think, we've done a lot about child sexual abuse in Australia, things like working with children checks and things of that sort. There's sort of much greater awareness of the harmfulness of child sexual abuse. But there are other areas like emotional abuse where people don't realise this, that emotional abuse where you're sort of constantly devaluing or belittling the child, for example, that is just as harmful as child sexual abuse or child physical abuse. In mental health terms, it's just the same. And people don't realise that is the case. And I think that is a preventive area where we need much greater awareness and much greater action.
Definitely going through the program is ideal, but if someone didn't do the course, but with a caring heart want to help their friends or family, is there any early sign, like how they realize that this person might need a professional help?
It's a hard one. Varies how you can see the symptoms and signs in different people. Some people are very private. They'll put on a mask and they'll go off to work and, be with their friends and interact differently. But then they come home and take the mask off and, they're absolutely exhausted and, can't say a good word about themselves and just feel horrible. When mental illness gets severe enough, you can't put that mask on anymore. You can't hide it. But you learn about the signs and symptoms. You can become more attuned to it. And I think it's when you can notice changes in the person from what they normally did. So the way their normal routine, how they interact, are they not concentrating as well? Are they getting more irritable? Are their eating habits changing? Their sleeping is changing. It affects all areas of life. And, if you really observe, you can see that someone's changing. Now, we know that sleep often is the first casualty whenever there's anything you're worried about, a problem or something or other. So just having sleep problems isn't enough. It's a whole cluster of symptoms. There's no one symptom to say, oh, there's a mental health problem developing. It's a whole group of things that can be affecting how the person's thinking, concentrating, how much they're contributing in the workplace, whether they're withdrawing, whether they're going out with friends, whether they're pulling their weight at home or at work, all sorts of things. Yes, it could be that they're crying more, but that isn't always the case. People may do that in private. People, when they're highly anxious, sigh a lot, and everything's an effort for them. Things slow down in the way they walk, the way they talk, in everything they do. What other symptoms, Tony? The workplace, at home?
I think the thing underlying all those things you described, Betty, is the person's ability to function in life and fulfill their normal life goals. If you see a change in their ability to do their work or to do their studies, if they're a younger person, or they're engaged in their relationship with family and friends, like if they're isolating themselves, for example, or you see a major emotional change, like Betty said, irritability or something like that. I think that is really, a sign that you need to take action to help them. Yes, Betty.
And it's not just for a week.
No, it's got to be lasting. Like everybody's going to have a bad day or a bad week. It's where it's lasting and it gets beyond their capacity to resolve it. Like people have episodes of distress in their life and they have strategies for dealing with that, and people around them have strategies for supporting them, and they can get better fairly quickly. But if it goes on for months, they're not functioning as they once were. That's where you have a role as a potentially supportive person. And as you said, anyone can do it. You don't have to do a mental first aid course. That might improve your ability to do it, but all of us can be caring people and can listen to people. I think the important thing is not to be critical. It's just so easy to be judgmental about people and to give advice and to be critical that, you should do this or you should do that. And the person could really control it if they tried hard enough. Well, they would if they could. It's not something that's within their easy control. And I think people can make critical comments thinking they're being helpful, but actually they're being quite harmful in doing it. They're very simple things people can learn.
Sometimes it's very easy to say, oh, I've been there, done that, and this is what I did, and this is what it was like for me. Don't do that. When someone's not traveling well in their mental health, don't bring in yourself too much. You may have experience where you can really rely on that to know how to show empathy. Think about, what would you want if you weren't traveling well? What would help you? So people don't want to just hear about you. It does sound selfish, and I speak from my experience. You're so in turmoil inside, you can't think of other ones. I mean, when I had a bad episode when the children were young, I'd hardly think to feed them. I wasn't hungry. My appetite gone out the window, and, my role was to prepare some food, and I'm not sure what I serve them, a little sausage roll or something.
I think also just what you were saying also about not minimizing too. So you can say, oh, things aren't really that bad, and
Don't do
but
that.
it's such a wonderful day, it's and you're really not taking it seriously. And again, the person can think they're being helpful by pointing out what a nice day it is and things aren't really that bad. But again, that's probably going to make the person feel worse, going to feel guilty or inadequate or something of that sort.
Absolutely. I had a dear old lady used to say to me, oh, Betty, it's a beautiful day. You can't be depressed today. Or, oh, Betty, you haven't got the problems like most people in the world have, blah, blah, blah. You just feel worse because you feel such scum. You feel so inadequate. You feel as though, "Oh, I can't even appreciate what I've got." Sorry. When you're depressed, you see everything very negative. And same with when you're suffering with high anxiety. You don't want to hear those sort of things. Or when you've got drug and alcohol problems, it's so easy for people to be judgmental there because they think, oh, you've just made bad choices. Just stop it, just don't go there and do that or whatever. It's not. It's an addiction. It's not just someone's will and their choice.
In those situations, then what to do? I mean, just ask them or take them to a professional. Now, professional means what? GP? Because in that cooking in your head stage, if someone sit down and like trying to understand which psychologist I have to go through, it will go to the whack anyway. So what is the best advice or to send them or help them to take him to the professionals?
That's why I came up with this action plan that, first of all, you learn how to approach the person. You don't go up and say, boy, are you in luck? I've just done a mental health first aid course, and this is what I learned, and I reckon you've got this, and this is what you should do. It's not the way. How do you approach the person? What if it's someone senior in your workplace, or what if it's someone senior in your family? How do you approach them? And so there's a lot of the teaching in the course, and we certainly worked on this in all the guidelines that were developed on how do you approach someone when you're concerned with some of the things that their behaviours or symptoms that you're seeing. And so if you do the approach right, the person then will be receptive and to be able to say, well, what do you think? What should I do? And that's where because you're listening and communicating non-judgmentally, you then can go on to the next action, which is give support and information, which is, this won't go on forever. This is an episode that will pass, and there's a lot of things that can help. There are professionals who are out there. There are some self-help strategies. There are some excellent websites that you can go on that are interactive, that will respond to how you answer the questions and what sort of help they'll give. You can get online, you can get telephone help. Fortunately here in Australia, there are a lot of things a lot of people don't know about, but they are out there. So once the person's listening to you, and they might say, oh, there's no way I'm going to the GP. The GP will just give me pills or send me to hospital. You can allay some of those fears with information to say, well, that's not the case now, to get you put into hospital, that you're going to have to be really very severe. But you let the person know what options are out there, and then they can choose. It's always important to have autonomy. They can say, well, I think this is what I'd like to try now, or whatever. So that's why in the action plan we have encourage appropriate professional help and encourage other supports. And in all the guidelines we've developed, it comes up with, well, what are these evidence-based other supports? So I think if you've developed the rapport and the person can see that you're not judging or forcing them to do something, and you'd say, well, here are the options, and then they can choose, that's so much more powerful. If they say, well, how about I do go to the GP? I mean, could you come with me? Or how about we write down some things together on how I may present this to the GP and what it is I want, etc.
And people often use and like self-help type strategies, and some of those do have evidence that they work, and some of them, like using alcohol, for example, are bad things to do. But you can encourage people to do self-help, like say, you want to come out and go for a stroll together, go for a walk, because we know that physical activity for depression and anxiety can be helpful, and you can encourage that very indirectly. You're getting the person out and about, getting them physically active, and getting some social contact and support by just inviting them out to do things, a very simple thing to do. And as Betty said, there are a lot of resources people don't commonly know, like in Australia, as she said, we have all these online therapy options now, which are fantastic, and they're free, all paid for by our taxes, they're freely available. Some are very good. One we often recommend is MindSpot, where you can do online assessment and they will suggest to you what sort of online program is best for you, and you can have a psychologist who you can talk to about that program and help guide you through it. And there are other programs of that sort that are really good.
I experienced depression in 2012-13, and that experience completely changed the direction of my life, and I would like to contribute into mental health field. But what I found that lived experience is welcomed in speeches, but not always in decision making or in funding space. And this is one of the undervalued skills or wisdom or values in mainstream. How we can engage more lived experience people into the ecosystem.
I think it's happening. It's been happening over the last decade or so. There are paid positions now for consumer advisors. Different health departments do employ them, but they're still few and far between. But certainly the nothing about us without us motto is being taken up by many organisations, and the lived experience is very important. We certainly welcome when people want to become mental health first aid instructors. They certainly have to bring teaching skills and delivery skills and knowledge to that role, but to have a lived experience is certainly a welcome thing for them. With myself, having gone through a number of episodes now, and certainly one I remember was I was a registered nurse. I've had a few careers. I've been a teacher, and then I had a really severe episode of depression, and then I decided as I was getting better I'd train to be a nurse, which was then training in the university, and it was free, I think, for the first few years, when it went from being like an apprenticeship nurse in the hospital to then becoming a degree. So I thought, well, I don't know whether I'm up to it, but I'll go and do some study. And I trained to be a nurse and did very well, enjoyed it very much, and got out as a registered nurse. But then when I was working, I think I was in coronary care, was I in the coronary care ward, where all the machines go whiz bang pop, it's a very responsible job, as all nursing jobs are. I then developed a severe episode of depression, and I was hospitalised in the psych ward. And I know when I came out, the CNC in coronary care said, "Oh, you've been in the psych ward. You can't work here," because she was older and had that stigma about that I was, permanently affected and disabled and not any good anymore, even though I'd come top of my nursing class. And she said, "We're going to put you to work in the aged care unit, so you can't do any harm down there in the aged care unit," which was terrible. You want to make things different. Now, I don't think you can immediately think, wow, I'm going to develop a program that's gone around the world like Tony and I have. I didn't have that ambition at all, but I did want to have the ambition that I wanted to make it better for other people. I didn't want them to go through that stigma that I went off. I remember also when I was sent to the psych ward, I still had my nursing uniform on. I think I was so unwell and I'd staggered off to work, and I was sent to be admitted into the psych ward, and I had my nursing uniform on. And I remember one of the nurses in the psych ward, she said, "Quick, you get that nursing uniform off." As though, that was a disgrace that you could see a nurse was being admitted to the psych ward. So yeah, I didn't want other nurses to go through that. I didn't want other people to have that judgment. And I think that was the motivation for wanting to write a mental health first aid course, not knowing how broadly it would spread. But I am satisfied to think that it has made a difference. I think what we've done has helped people.
I think just to add to what Betty said, following your question, is we are seeing development of a peer workforce of people who have had experience of mental illness, who are then becoming professionals who provide services to other people who are having that experience. There's availability of training in that area. We're seeing a big trend in Australia towards what they call co-design, which is when you design some program or intervention, you work with the end users as partners in it all, rather than professionals designing it and we're giving it to you, the end users. I think that is a strong trend. And as Betty said, consumer advisory committees and so on have been around now for a couple of decades and are becoming important. I think all of us, you just got to start small and start local, because not everybody's going to do these big things that change the world. In fact, we didn't. We just had a dog walk and said we're going to do a couple of courses a year. That's all. You just start local, start small. You get 1 million people who all do a small thing that adds up to something very big, rather than one person does a big thing. So I'd say just do something local, do something small, encourage other people like yourself to do something, and it'll all add up to something great.
With all these Education definitely incorporates, there are mental health first aider now. People are aware of a lot of education, information, and some mandate also came in Victoria around psychological health. What I am not very clear is, let's say, a person going through a hell in the family front, and in that headspace, he is going to work. So definitely he is not in a full mood, full productive, and to do their jobs. How, I mean, it's not possible for organizations to look after their psychological health in their full life capacity. But how we evaluate that, that person is not perfectly all right, support him or her, how we go about it?
We're not familiar with the Victorian legislation that's currently around, but you're absolutely right. I mean, if somebody has mental health problems at work, it may have nothing to do with the workplace, because people have other lives outside the workplace. There may be, big relationship problems or financial problems they're having outside. They could have had a traumatic experience, been a victim of crime. All sorts of things could have happened that will impact their work. The workplace is not the core, the causal factor there. On the other hand, it can be, people can have bad interpersonal experiences, be overworked, feel a lack of control at work, feel they've been mistreated, and those things can be important. Or you can have a combination of both. But I think, workplaces do, without knowing the Victorian legislation, they can make adjustments. Like if you're a supervisor or someone, whatever the source of their distress, whether it's from inside the work or outside, you can try and make adjustments to try and help them manage during that period. Whether or not the workplace is the cause, you can take some pressure off them to some degree. I think that's not going to add to any distress they're experiencing from outside. And if they're in a situation where their distress gets to the point where they need to take leave, you really need to have a plan to try and bring them back in and welcome them back at work when that distress relieves, to ease them back in. So whichever way, whether it's workplace related or not, or a bit of both, I think workplaces still can play a role in assisting the person's recovery.
I think the core things that come out of the mental health first aid course that really help for employers, employees, family members to learn is that mental illness is an illness like any other illness, and the mental health first aid course starts off with trying to define what we mean by mental illness, and then to look at, as you talked about before, the burden of disease. I mean, just how disabling having a mental illness can be, and people don't realise. And when we have a lovely little exercise that's done in the mental health first aid course that gets people to compare the disability from perhaps having a physical illness such as asthma or epilepsy, compared to, how disabling an episode of particular mental illness may be, is really a difficult illness, and how people are suffering, and it's not through any fault of their own. And I think when people realise that, it changes their mindset, that they're not so judgmental. And I know just an anecdote that always stuck with me when I first started delivering mental health first aid. And at first, when I delivered them, it was very much for the community. Yeah, I'd run them in the evening after people went to work or on the weekends. And I don't know how many people would come up to me, family members, and say, why weren't we taught this before this? My son, when he was an older adolescent, he went through a psychotic episode and he was doing this and doing that, and my husband stood up to him and had fisticuffs with him, which is exactly what you don't do when someone's in a psychotic or disturbed episode. You don't just threaten and bash a bit of sense into them. It's not possible. It will only make things worse. And I don't know how many parents said to me, why haven't we been taught this before? If only we'd known, we would have handled this situation at home, at work, so differently. And I couldn't answer that question. I don't know why someone else hadn't had a dog walk before we had a dog walk and come up with this idea. I don't know.
Can you please explain some coping technique if someone is distressed? I mean, still not gone to that phase where professional help necessary.
Do you mean that if you personally were distressed, how could you cope, or if you wanted to offer help to someone who's distressed.
No, we heard a lot of how to help, but if
Mm.
someone is distressed and want to help himself.
Mindfulness has, I mean, you've probably, a lot of people would have heard of that term. It has a lot to offer here, which is really about learning acceptance, learning to accept what's happening, to sort of become a little bit removed from it, to not be so emotionally reactive to it, to think on a scale of 1 to 10, where 10 is I'm dying slowly under a mudslide. Where would I put myself with this distress that I'm going through? It helps you not to catastrophize, to stay calmer, to think more objectively, to sort of step out of the distress that you're in. They're great skills to learn, and it'd be best to learn those skills before distress ascends you, because once you are in a very disturbed state, it's hard to pull yourself out, and that's where you hope you've got a friend or a supporting person who can help to change your mindset. But people learning relaxation, just learning just some deep breathing skills. We do have guidelines on what to do if someone's having a panic attack, which is being in a state of high anxiety. And how do you help them come down from that? And again, it's trying to get their focus away from what's happening inside them, where they think maybe I'm going to die, to focus out, to look at something out, to get them to concentrate on something else, to watch you to do some deep breathing, and to let them know it will pass. You have to give hope. I mean, you don't know what the outcome will be, but when it comes to mental illnesses, they're usually episodes and people do get through them. And with support, the right support, people will get through it faster. So when someone's in a very distressed state, you need to give them hope. How you give that to yourself, because you want me to answer if you're in a distressed state, yes.
I think for people with, you're dealing with people who may be like crisis, like a panic attack, but then there are also people who are, their emotions are beginning to get a bit beyond their control. They've got sort of milder problems, and there are a lot of self-help things that are known to be effective there. So, to like get out and do things is very important, because when people can get into that state, they can lose motivation and not do things, and they can usually get into a spiral. So it's important, to get out of the house, do something each day, to set a small goal, even if you don't feel like it. Today, I'm going to pay this bill. Today, I'm going to do this washing and hang it out. Today, I'm going to mow the lawn, whatever it is, set a small goal and achieve it. To seek out social contact, even if they don't think it, to go out and have a tea or coffee with somebody, to go for a walk, walk the dog, walk around the block. Very simple things like that can stop the person or reduce their chances of spiraling down. Betty mentioned relaxation techniques, things like meditation, progressive relaxation can have important effects on anxiety and depression as well. And people do spontaneously often use these methods to deal with, distress, milder forms of distress, and they do work in most cases. But it can be difficult for people to have the motivation to do them, and often it's good if somebody else can encourage them. So, well, do you want to come out? I can see this person's not going, so, well, do you want to come out for a walk with me? We'll have a chat and we'll walk down the park, or can I go walking your dog with you, or something like that? Or do you want to come out for a coffee? Do you want to go to a movie together? All of those things can help the person re-engage and not spiral down into sort of a depressed state. Yes, Betty?
I think a point to make also is that the importance of not doing things to avoid the distress. So, I mean, often, like let's say a panic attack, you're absolutely inside a shopping centre and you're just overcome with this overwhelming anxiety. You think, oh my God, my heart's racing, I can't breathe properly, I've got to get out, and you run out of the shopping mall, and things calm down. Sure, you're feeling better now, but in the long term, it's going to make it worse. You haven't learned any coping mechanisms for that. You can't always run away. You have to actually stay there, let the stress roll over you. As long as you can say, it's all right, it's just a panic attack, it will pass, I'm having a lot of stress now. So even in a situation where it's not a panic attack, where someone just feels so stressed, there's long-term stress going, try not to get into avoidance behavior, because in the long run, it's going to be harder for you to recover.
Whatever little data I have, Australian government spend around like 14.5 billion annually on mental health related services. A major portion of it goes to treatment, which is around 65%, while early intervention is only around 10%. Primary prevention makes up a tiny fraction of that. And what you are basically saying is spend more time, more energy there so that people won't reach to that problematic state. So is it the right model or some better model you already working on or already proposed, or Australia will come out with some new plan?
I don't know about the actual dollar figures, but the general point you make is absolutely true. We put vastly more resources into helping people after they develop a mental health problem or mental illness to try and help them recover, and minuscule into trying to prevent them getting that problem in the first place. And certainly there needs to be a greater balance in that regard. It may be appropriate that you spend more on treatment services than you do on prevention, but the imbalance at present is just absolutely ridiculous. As you get people, help them, get better and recover, there's going to be more and more people developing problems. So they're just going to go and fulfill those roles, sick people, get into treatment services, and it's just going to be an endless sort of conveyor belt, as it were. And I think we really do need to rethink about this. I think preventive interventions need to be more than what health departments do and what health practitioners do. We need to think more in terms of like everything that governments do has a potential effect on either reducing or increasing risk of mental health problems right across the board. We know that if people are in debt or have trouble getting housing or they're unemployed, all those things increase their risk of mental illness. And those things aren't necessarily controlled by the health department. They're affected by actions in other areas of government. So I know in some countries they're talking now about what they call a well-being budget. Treasury in Australia is going a little bit in this direction, where when you think about what are our goals in society in taxing people and then spending that money for the benefit of the community, what are the ultimate goals there? Is it growth in the economy, or is it the well-being of our population, including the mental health of our population? And I think it is, well-being and mental health of our population is a fundamental reason for what we're doing. We all want to have productive, satisfying lives. And so I think across all areas of public activity, we need to be considering what are the mental ill health implications and designing policies much more around that. So prevention then becomes like a whole of government, whole of society aim rather than a narrow health services aim. But again, yes, we're really not going to get anywhere if we just keep increasing treatment services without also doing something about prevention as well.
Few questions, which is basically tips to our audience. So what's the most powerful sentence someone in emotional pain can hear?
Acknowledge. I can hear and see that you've got a lot of emotional pain. I can hear things are really hard for you. So acknowledging, not judging it, not giving any rider to, you really shouldn't be feeling this bad about it. Really acknowledging and accepting. You don't want to dismiss or minimize the emotion, even though you may think the person being a bit dramatic or whatever, you don't understand from their point of view why they are in such emotional pain. So accept it as they're telling you, acknowledge it to them, and let them know that you want to help. They need to be given hope.
What question do you wish someone had asked you during your depression period?
How can I help you? What can I do to help you? Is there someone I can get to help you? If I can't do it, is there someone you'd like me to find? Don't ask too many questions. Sometimes when you're depressed, whatever question the person gives you, you'll see it negatively. You have these special little antennae, and you'll interpret it as them judging you or thinking, if they ask a question, why or what or when, you think, oh, they're judging me, especially asking why. Probably better, rather than what question do you wish someone had asked me, it's probably more of what statement they gave me, which is, I'm here with you. I can see that you're not traveling very well now. I'm pretty sure it will get better. There's a lot known about this. Other people have had this low mood or this distress, and many, many people get through it. And I'm here to help you and to seek the best help for you.
What is one mental health myth you wish you could erase from society forever?
I think that people with mental illness are weak people, that they've made bad choices. They've chosen to be soft, or they've chosen to be, feeling sorry for themselves, or with drug and alcohol, they've chosen, a silly path, made bad decisions. It's an illness like any other illness, and most people are not to blame at all for their mental illness.
And the last one, what is one thing families often get wrong when supporting someone experiencing mental distress?
Being judgmental, saying, come on, I've been such a good parent to you. I've been with such a good family. You're so lucky. This is the best family in the street. You've got, we've got a swimming pool and no one else has, or whatever. Making the person feel even worse. You're not, the person isn't being negative because they want to be. They dash well wish they could be better, but at this moment they haven't got the skills or the wherewithal to think differently, to act differently. So again, it's that acceptance. Darling, I hear that you're in emotional pain. I'm really sure that we can get through this together. I'm with you. I've got your back, and we're going to find out. I know there's lots of things that can help, and we're going to find out what they are, and we're going to get them. Hope.
On that, we should end our podcast here. Thank you, Betty. Thank you, Tony. Again, it's an honor and privilege.
Thank you for asking us to be interviewed. Great opportunity to get messages out to the community.
And you're doing a wonderful job. Thanks, Guta.
Thank you.